here, huh? Right, okay.
A very warm good morning, one and all gathered here on this wonderful morning for the third day webinar. I would like to welcome Honorable Chief Guest, Mrs. Anjali Ma'am, our Chairman, Dr. L.P. Thangavelu Sir, Mrs. Shanti Ma'am, Correspondent, Joint Correspondent Mr. Akshay Sir, Principal Ma'am, faculties, and my dear friends. As a part of Breastfeeding Week, we have completed the first and second day breastfeeding webinar successfully. Leaders are not born, they are made, and they are just like anything else through their hard work. I request Dr. K. Jayabadi Ma'am, HOD of Child Health Department, to give a welcome address.
A warm and happy morning to one and all gathered here. First, I would like to welcome our Honorable Chairman, Dr. L.P. Thangavelu Sir, Mr. Shanti Thangavelu Ma'am, Correspondent, Mr. Akshay Thangavelu Sir, Joint Correspondent, PPG Group of Institutions, for their constant support and guidance. I welcome you all. I extend my heartfelt welcome to our beloved Principal Ma'am, Dr. P. Muthulakshmi Ma'am, for her motivation and constant support. I welcome you, Ma'am. And happily welcome the speaker of today's session, Ms. Anjali Baji, Perinatal Nurse Preceptor from Florida. And probably we can say that she is alumni of our College of Nursing. I welcome you, Ms. Anjali. And I extend my heartfelt welcome to all my dear friends, colleagues, and my dear students for this wonderful third day webinar. On behalf of our PPG College of Nursing, once again, I welcome all the participants from various institutions of this webinar. I welcome you all.
Thank you, ma'am, for your warm welcome. I request our Principal Ma'am, Dr. Muthulakshmi Ma'am, to address this gathering.
See, my dear Anjali, God bless you. See, I am very happy to see you in this webinar. Actually, you are very intelligent. Just I joked before. Okay. When you were student that time, really you are very outstanding student. I know very well. Anyway, see, I am very happy to see you after few years. Not long ago, I think, isn't it? Now you are. You are present or you are pleasant look, first of all. Then I am very proud that you are in abroad to work and you are earning a lot of money and other things. Married, huh?
Married, madam.
How many kids?
Madam, son 5 years, pregnant, madam, for 6 months.
Fantastic. நல்லதப்பா. டெலிவரி பண்ணிக்கோ, நல்லபடியா இரு. நல்ல எல்லா ஐஸ்வர்யங்களும் உனக்கு சாமி கொடுக்கட்டும். சரியா? Okay. I'm very happy that our Anjali is very good in all aspect. Very silent and she did a lot of things to our college and other things. Good girl. That's all. Really, we feel our students are doing like this means that is another சொன்னோம் இல்லையா இதுலயே ஈன்ற பொழுதில் அந்த பிறந்த குழந்தை வந்து பெருசாகி அது நல்ல ஷைன் ஆகிறப்போ ஒரு தாய் எவ்வளவு பெருமைப்படுவாளோ அதை விட அதிகமா நான் பெருமைப்படுறேன் அஞ்சலி பாக்குறப்ப. Anjali, God bless you. God give all the Aishwaryam to you. Okay, thank you. You continue, my dear.
Thank you, ma'am. Thank you, ma'am. Now I request Professor Priya ma'am, OBG department, to introduce the today's speaker.
Good morning, everyone. Your alma mater is like a mother. Patiently accepts all your hopes, but proudly posts your achievements to the world. We feel very proud to introduce our alumni speaker, Ms. Anjali Baji, who is a nurse preceptor in Advent Healthcare, Florida, United States, on optimal breastfeeding practices. Every mother and a child, no matter their location or a circumstance, should benefit from the optimal breastfeeding practices. But there is a substantial gap in the knowledge and the skills to support the breastfeeding are reported at all levels of care. To bridge these gaps between the knowledge and the practice in breastfeeding, we have with us our alumni, Ms. Anjali Baji, who pursued her bachelor's in nursing from SSNM College of Nursing, Kerala, and done her master's in pediatric nursing at PPG College of Nursing in 2012. And she extended her service as a lecturer in Travancore Medical College, Kerala. And she worked as a nurse preceptor in St. John's Providence Hospital, Novi, United States. Currently, Ms. Anjali is working as a nurse preceptor in a mother and a baby care unit in Advent Healthcare, Florida, United States. To add to her credentials, Ms. Anjali had received a Nurse Excellency in Michigan for her contributions in the field of nursing education. Our guest has 10 years of experience in the field of nursing education, and she is highly dedicated and she maintains a strong reputation for achieving high levels of patients and the student satisfaction. We are awaiting to listen to you from Anjali. Please take over the session.
Thank you, ma'am.
Thank you so much. Thank you, Priya. First of all, good morning. Evening a bit night. I'm very happy. It's such an honor and it's such a blessing to be here today. When Jayabharati madam called me the first time, seriously speaking, I first felt like, okay, it's gonna be like the first time I did my master's first seminar. I'm sitting here with so much of nervousness, it's so much of pride. I'm so happy to be here today. It's such a wonderful opportunity for me to talk in front of all my teachers today. So I really want to extend my wholehearted, very blessed thank you. I want to express my sincere thanks to our chairman, Dr. L.P. Thangavelu sir, and then Shanti madam, our correspondent, and then joint correspondent, Mr. Akshay Thangavelu, and my beloved principal madam. I can always tell she's like the mother for that whole college. I can always tell my husband, my parents, whoever knows me, they know about principal madam, and very beloved Jayabharati madam. She's been my like ever best role model. Like wherever I go, and at least like once a day, I'll remember whatever she has taught me. Like wherever I go, there is something when I talk to my patients, when I talk to my students, there would be something that would come out of my mouth, which will remind me of all of my best faculties I've ever had with PPG College of Nursing. I really want to express my sincere gratitude to Kalaivani madam, and I don't know, Rajlakshmi madam, like every single person. Shamla madam, I was listening to Shamla madam yesterday. So I really want to I take this occasion to thank every single person who has been in my life, who has helped me to gather all this information and be here today. So thank you so much, Muthalakshmi madam. Your words were so kind. It's such a blessing. There is nothing more than that I can ask for today. It's such a blessing. And then seeing Jayabharati madam over here, she has always been and she will always be my back support. I know that. And I really want to address to every single person who are here. You're so blessed to have such a wonderful faculty, and you're going to be like well-trained professionals when you come out of this college. It's such a blessing for you guys. Is that okay if I start my session, madam? So today's session, we're going to deal a little bit more about optimal breastfeeding practices. Today, yesterday Shamla madam has been talking a lot about breastfeeding. So this week has been like professionally and officially has been like celebrated as the breastfeeding week. So I know it's a little funny here. So breastfeeding and optimal breastfeeding practices. So when you see in this picture, so breastfeeding is such a normal thing which has been carried out very universally. When you trace back to the evolutionary history, it has been dated back to like hundreds and millions of years. So I was reading back to see what's the history of breastfeeding. So obviously the history began like millions of years ago, ever since the mankind was found on the spheres of Earth. So when the mankind started, breastfeeding was obviously there. But I think it was towards the end of 18th century, a lot of research started happening, proving the benefits of breastfeeding. A lot of research started happening, like what exactly breastfeeding is. Till then, it's just a normal thing. It was done by everything. There was a group of scientists. It's called the Lenosis grouping. They were the first people. They brought about like multiple aspects. They brought about like multiple ideas about breastfeeding. Some of the ideas were like proven wrong, but some of them it came out to be right. So one among them, they named a group called Mammalia. Mammalia means mammals. Mammals means the ones who have mammary glands, which means breast tissue, who are capable of breastfeeding. So the group of scientists, they're called the Linosis grouping. They came up with this idea called mammals. The mammals are the ones with the mammary glands which are able to breastfeed. And it has got a wide variety of, you can see over here, it's starting from cow, we have elephant who breastfeed, we have pig, we have chimpanzee, we have monkey, we have deer, we have whale, we have seals, and we have humans too. So human is like one part of the ecosystem which belongs to the group of mammals which is able to like breastfeed. So what we understand from this, the breastfeeding is universal. This is something which has been done by many different, like you can see over here, or different parts of the mammals, and they do it in a universal way. And this is such a normal thing that has to be carried out by the mother for the betterment of the child. So that's called breastfeeding. So we are just, this is a beautiful picture of, it's called the tree of life. So you can see towards the right side, there's this beautiful roots which goes from the mother, it gets onto the child and it nourishes, and it goes as a branch which is nourishing the child. It goes into their brain. It's called the tree of life. So breastfeeding and the breast tissue, it's called the tree which nourishes the further development of a baby. Let's see a little bit about the physiology of breastfeeding, because this physiology is going to help us in a really lot of ways as we move forward with the class. So the first and foremost thing, the slide might seem a little complicated. It's a little bit of an anatomy. I'll make it like really simple for you guys. So this is like, as soon as you can see, the baby latches onto the mommy's breast. So as soon as the baby latches on, there's a stimulation of the breast tissue. So the breast tissue, if you can see over here, I have a tiny, can somebody just tell me if you're able to see this? Mara, are you able to see this?
Yeah, you can.
So this tissue, so this is called the nipple, and the area surrounding the nipple is called the areola tissue. So it has got a ton of sensory neurons. So when the baby latches on, what happens is like the sensory neurons take this as a message. So when the sensory neurons get activated, a message is sent from these sensory neurons to your brain. So what happens in the brain is that the hypothalamus, the part of the brain, the hypothalamus is the one that controls the pituitary glands. So the pituitary can be broadly classified into two, the anterior pituitary and the posterior pituitary. You can see it over there. The anterior pituitary is the one that produces prolactin, which helps with the milk production. And the posterior pituitary is the one that helps with the production of oxytocin, the hormones that helps with the milk letdown. So this is the basic physiology. So as soon as the baby latches on, that's the first step. As soon as the baby latches on, the neurons picks up the message, it goes to the brain, and the whole thing, then it's a hormonal thing, which helps with the production of all these hormones, the two major hormones called oxytocin and prolactin, which helps with all this milk production. So we should understand the first and the foremost thing comes when the baby latches on. So that's the most vital thing, which is called breastfeeding. So this is something like I would always like you to keep in mind, because the first and foremost thing should be the baby latching onto the mommy. So that's a little bit about the physiology. So the only thing you have to keep in mind is like two major hormones that help with breastfeeding are the oxytocin and prolactin, which comes from the pituitary glands. So yesterday I was listening to Shamla Madam. So we don't really have to go a lot of into the benefits of breastfeeding. It's broadly classified as benefits for the baby and benefits for the mom. So Shamla Madam, as you have listened to Shamla Madam was telling, it definitely helps with like reducing the incidence of SIDS, so that's sudden infant death syndrome. It helps with the IQ formation. Breast milk has got like a wide range of antibodies, which is really good for building up the immunity of the child. It helps with the bonding for mother. And then it helps also with the diarrhea, reducing the diarrhea mortality rate, reducing the chances of pneumonia. And so there's like immense benefits for the baby, which the baby gets out of the breast milk from mom. Whereas for mommy, it's really helpful for the prevention of breast cancer, prevention of ovarian cancer. There's a lot of women who go through postpartum depression, but breastfeeding is something that has proven to reduce the incidence of postpartum depression among women. and again type 2 diabetes, it reduces the stress level. I would really like to share something with you at this moment. We have had mommies over here who would come onto the floor. They will be in so much pain. Their blood pressures will be very high. As soon as they start putting the baby to the breast, or when they start cuddling with the baby, when they start bonding with the baby, their blood pressures has seemed to be coming to a very lower levels. So how much relaxing it's to cuddle, to do a skin to skin, and to do breastfeeding that relaxes mommy to such a level. There is lower chances of high blood pressure. It reduces the high blood pressure. It helps with the postpartum depression. It helps with their anxiety disorder. So both physically and physiologically and psychologically, mothers are benefiting from breastfeeding, and also to some extent it helps with the family planning process too. Even though we tell them it helps with family planning, it's not 100% security, but it partly helps with their family planning process too. So next slide. So what are the optimal breastfeeding practices, and who has put forward all the optimal breastfeeding practices? It's like a basic 3-step process, which has been put forward by a collaboration of IFPAN and UNICEF. So IFPAN is the International Baby Food Action Network, and in combination with United Nations Children's Emergency Fund, so that's the UNICEF. So these two, they came collaborated, and they have put forward certain steps and principles and policies and protocols. They put everything together so that we can have a set of practices that can be put forward for which can be taught to each and every mother, so we can have an effective breastfeeding experience. So the first thing is, the first and foremost thing would be the early initiation of breastfeeding. So when I say early initiation of breastfeeding, it's trying to put the baby to the breast as fast as possible, as soon as they come out of the mommy's womb. So you can see the picture over here. The baby was just born. So it again depends upon the scenario. Say if we have a 28-weeker or between a 28 and a 33-weeker or a 34-weeker baby, early initiation may not be possible because the respiratory needs comes prior than the early initiation of breastfeeding, because breastfeeding will be categorized as the second one compared to their early needs. So recently, we have been getting a lot of COVID babies over here. I know in most part of the world, it has been the same scenario. But with the second wave, we have been getting a lot of pregnant mommies with COVID. And recently, we were getting some of the 28-weeker babies, 30-weeker babies, 32-weeker babies. So the problem with the 28, 30, 32-weeker problem is they don't have a sucking and swallowing reflexes that is coordinated. So when you don't have a sucking and swallowing reflex that is coordinated, breastfeeding is a big challenge for us. That's something we have to push it for our next category. And again, so what happens if you have a healthy baby and a healthy mommy, a well baby, a 36-weeker, 37-weeker, so anything past a 36 to 37-weeker, they are considered more healthy, more stable. They don't have any issues going on. We need to initiate the breastfeeding as soon as possible. So the first 5 minutes is definitely assessing the baby. You'll be you'll be checking on the baby and making sure everything is fine. We do the UPGAR scoring. And the cord clamping is kind of some of the babies we delay the cord clamping, and some of the babies we might do the cord clamping as soon as possible. So anytime when we get a 36-weeker to a 41-weeker, some of the babies can go up to 6 and 4 days, even though it gets close to the post-term dates. You can start breastfeeding as soon as possible. So when we say as soon as possible, it would be the first hour of birth, the first hour of life. So after 5 minutes of all the assessments, say for you catch the baby, you make sure the baby is good. The second thing that we do is we put the baby to the mommy's breast. So they go into stages of 9 as soon as you put the baby to the mother's chest. The first thing is you receive the baby and you make sure the baby is good. UPGARs are fine. It's a normal baby. It's a stable baby. The first thing you do is you put the baby to the mother's chest. But again, when you say put the babies to the mother's chest, it's a consent. You ask mother, because some of the mommies would say, no, I don't want to do that. Make sure you clean the baby before you put the baby on me. Some of the mothers would be no, it's fine. Just give me the baby. They want to do it more organic way. So we always check on the mothers to make sure what kind of early initiation they need. As long as they said if everything is normal with them, we can put the baby to the mother's chest as soon as possible. We are not putting the baby to the breast. We are putting the baby to mother's chest first. So that you make sure the baby's crying. That's the first stage. They cry, and that's when they take deep breaths and their oxygen saturations are better. And then when you put the baby to the mother's chest, they start relaxing more. Because the reason for the relaxation is like when the baby is on the mother's chest, the baby can hear mommy's heartbeat, which the baby was hearing for 9 months. So that's like a relaxing for them because it makes them feel more they're on the intrauterine life. So first is the cry. Second, they listen. They are with the mommy. They can feel the warmth. They relax. And the third thing is like they will slowly start awakening. They're moving around. They will try the so it's awakening means they will start like their senses are getting more active because the first 24 hours of newborn life, it's a transitionary stage. Newborns don't really realize they came outside the womb. They are in a confused stage. They're like, well, I think I'm inside the womb. And then at one point they will be like, no, I think I came outside. So the first 24 hours is a very confusing stage for the newborn. So that's the reason we call it like a transitionary stage for them. So we have to be a little bit more patient on their first 24 hours. So you put the baby over there, the baby starts moving and baby starts exploring stuff. They try to get a little bit of a rest. And the next process is called baby crawling. I do have a tiny video of that, which I will show you in a minute. Um, so the baby starts crawling and the baby gets so from the chest, when you put the baby to the chest, the baby is like moving, it's trying to explore the stuff, and then it will start moving towards mommy's breast tissue. And then the baby gets close. When the baby gets close to the areola tissue, the baby will start sucking and will start breastfeeding. By it's like a very normal automatic process. It's like the baby knows what to do. So when it means to the early initiation, you're putting the baby to the chest and giving it time to familiarize and to like get to know the mommy and to get to move to the breast tissue in a very natural process. It's called baby crawling. And then they would start sucking. You can do a little bit of hand expression. You can help with like, you can always hold the breast tissue for the baby. So when you hold the breast tissue, you try to hold it like a good sandwich. Like, because if you don't hold it, the breast tissue can be a little bit more flat. So we usually tell mommies when the baby gets close around the nipples and the areola tissue, we ask them to hold it from both the sides in a way. So when you hold it, you can see the breast tissue gets more prominent to the point it's easy for the baby to latch on. So rather than just leaving the baby there, once the baby gets close by, we help them a little bit by holding it like a good sandwich. So the baby can latch on much faster. The baby will start sucking. And the final stage is like they will suck and they can eat maybe for like 10 minutes. Some of the babies can go for like a good 15 to 20 minutes and they go into a deep sleep. So these are the phases that they go through when we do an early initiation of breastfeeding. So it's very simple. Like you get the baby, you make sure it's a stable baby. Upcards are good. Like say for you, the upcards are like 8 and 9. But even if the upcards are like 6 to 7, and if the baby's breathing, and in the 5 minutes scoring, if it's like an 8 to 9, then it's good. Don't be really worried when the upcards score less than like a 5. So we'll keep a close eye on the baby. But otherwise, if the baby's breathing fine, if everything is good, this is the first step that we do. We will put the baby to the chest and make sure they go through this 9 stages. Some of the babies can skip the stages, but it's still like baby cry and relaxing and familiarization, everything happens. And they will pretty much go through at least like 5 of these stages. When we say like stages of 9, at least like 5 or 6 of the stages, but it's very normal. They go around all the stages. I do have a small video of the baby crawling.
Mother's bacteria rather than the hospital bacteria. The baby has better respiration. And of course, skin to skin immediately after birth gets breastfeeding off to a good start. Research has shown us that babies go through 9 instinctive stages when skin to skin with mom immediately after birth. They are the birth cry, relaxation, awakening, activity, rest, crawling, familiarization, suckling, and sleep. But what could keep a baby from behaving in this instinctive way? A new study was published October 15th, 2000.
So if you have seen around 1 minute and 15 seconds, you can see the baby crawling towards the baby mother's breast tissue. The baby slowly moves and it gets onto the breast tissue. One of the major things, we have always wondered, how does the baby know to get onto the breast tissue, to the areolar tissue? They know, once they get close to the areolar tissue, they latches on immediately. This has been always a question. It's like as if they know what to do when they get onto the areolar tissue. So the reason for this is they have been recently a lactation class. It was an advanced program, and I happened to get a chance to be there. So the consultants over there, they've got 30 years experience with teaching breastfeeding. They're pros of breastfeeding. They have done teaching breastfeeding and helping lactation. They have written books on lactation. So they were 60-year-old, really senior people. So they were saying the breast tissue and the areolar tissue has the same smell of the amniotic fluid. So the amniotic fluid is the same thing. The baby was inside the tummy for 9 months. So they're very much familiar to the smell of the amniotic fluid. But for some reason, it's a nature's gift. The breast tissue or the alveolar and the alveolar tissue has the same smell of the amniotic fluid. So the baby knows the smell of the amniotic fluid. So once they get close to the breast tissue or the alveolar tissue, they latches on immediately. So that's the reason babies know when they get close to the alveolar or areolar tissue over here. So again, the next is the periods of reactivity. So we have been talking a lot about early initiation, when we keep telling you have to put the baby to the breast as soon as possible. And the best thing to do is after the first 5 to 10 minutes, try to put the baby to the breast. And then when it says early initiation, it has to be done within an hour. That's called the early initiation of breastfeeding. So whether it is normal vaginal delivery or if it's a C-section, we can still do the first hour breastfeeding, because if it's a C-section, once you take the baby out of the mommy, there's nothing else that can be done. You can put the baby stable, then you can put the baby to the mother's chest, because the doctors are working with the incision closure and all that stuff. So babies can still breastfeed. There's nothing interfering with the type of delivery that they go through. If it's a vaginal delivery, if it's a C-section, you can always initiate the early initiation of breastfeeding. So what is the reason? We keep telling put the baby to the breast as soon as possible, but there should be a scientific reason to substantiate the fact that the first hour is very important. The reason is periods of reactivity. So we all might have learned about periods of reactivity. There are 2 periods of reactivity which the babies go through after delivery. So there's the first period of reactivity, and then there's the second period of reactivity. So the initial period of reactivity is from birth to 30 minutes. So this will make things more clear for us. So there's a period of relative inactivity after the first 30 minutes for the next 2 hours. And then they go into a phase of stability. So what happens is there is a pattern. This periods of reactivity is the baby, in the first period of reactivity, the baby is just outside the womb. Their senses are more alert. They're breathing faster. Their heart rate is faster. They can hear the sounds. They can smell much better. So they are more active and alert. Their senses are more alert and they are more active and they wanted to explore more stuff. So that's the reason the first hour is said to be very crucial with breastfeeding, because after that first 30 to 45 minutes of reactivity, they go into a deep sleep of at least 2 to 3 hours. So if you don't get to breastfeed the baby in the first 30 to 45 minutes, then they're going into a period of relative inactivity, which is almost 2 hours. You don't get nothing to do with the baby. Some of the babies you can try like waking them up, but it's really hard to get them awake and have breastfeeding during a period of relative inactivity. So that's the reason we say when the baby is going through the first period of reactivity, try to get the baby to the breast and try to do a good 15 to 20 minutes of breastfeeding. So as the slide that says over here, the presence of periods of reactivity, it indicates a positive adjustment of extrauterine life, because some of the babies, they come up with a low Apgar score of like 2 and 3 and 4. They need like intubation, respiratory support. They might need like an NG tube insertion and all that stuff. So those babies may not go through these periods of reactivity because they're all like beaten up when they come up. So those well babies, they definitely go through this because it shows like they're adjusting well to their extrauterine life, because it's a transition between the intrauterine. They were not breathing. They get everything through their cord. So when the baby comes outside, it's a lot of adjustment that happens within the body. So when the baby goes through the periods of reactivity, you get to know that it's a positive adjustment. So that's the reason in the first period of reactivity, you try to breastfeed the baby as soon as possible and as much as possible. There's always like questions as like how many minutes do we breastfeed? Well, if you get to have a baby on the breast for 15 to 20 minutes, that's the best thing you can do for a baby, especially in the first hour. Sometimes we get babies over here, but in the first hour they sleep for like 25 minutes, 35 minutes. Seems like the baby was like really hungry when they came outside. They really latches onto the breast and they would be there for like 25 to 30 minutes. Some of the babies will be there for like 10 or 15 minutes, but still it's fine. You initiate the breastfeeding. So the first period of reactivity is like well utilized when you put the baby to the breast. So the physiological adjustment to extrauterine life. This is what happens physiologically during the periods of reactivity. In the first period of reactivity, which lasts for half hour, but it can go up to like a 45 minutes, this is what happens. Baby is alert and is exhibiting and exploring searching activities. So it means like the baby's searching for something. It's trying to explore stuff and it's making sucking sounds. It's very funny to say, like some of the babies will come outside, they will have sucking blisters on their hands because they are so used to like sucking their thumb inside the tummy to the point when they come out, they will have tiny blisters on their hands. So the baby is making active movements even inside the tummy. So baby is coming outside, baby looks like sucking. The baby will be like moving and baby will start like sucking on the fist, which means like the baby is hungry. These are the cues. It's called hunger cues, which we pick up on and which we know is like, okay, it's time for breastfeeding. And the baby will have rapid heart rate and respiratory rate. So when you see all this, which means like the baby is going through the first period of reactivity, which is the best time to go ahead and start breastfeeding. So it lasts for the first hour. You see for all this reflexes. So you see your heart rate is going, the baby's heart rate is on the higher side, respiratory rate is on the higher side, baby's sucking, baby's exploring, and you can see the baby will be moving the face from one part to other, looking like as if it shows like it's searching for food. It's looking for mother. So you know that that's the best time you will put the baby to the breast. And once that period of reactivity is over, after like that 45 minutes, what happens is like they go into deep sleep. Like it's almost like an hour and a half, like 90 minutes to like 2 hours. Baby is like sleeping. No dosing, there is no epidural. They don't have to have any medications during pregnancy. Fentanyl is one of the major drugs which can make the baby a little sleepy and loopy. So the more the drugs which we use during labor, a part of it gets onto the baby too. So that's the reason, like they definitely go into a resting stage. But if you have a mommy who has gone through a long, prolonged labor, that baby is going to be more tired because the more the mommy has been pushing, the more the contractions. Especially when you have a first-time mommy, like we call it primigravidas, when it's a first-time pregnancy, their labor can long for at least 18 to 20 hours, which is normal for a first-time pregnancy. So 18, 20 hours, this baby is inside the tummy, is getting all these contractions, and the baby has been like squeezed out. So baby, it's very normal. They go into a sleeping cycle. So it's first hour is vigorous activity, and they go into a sleep. And then comes the second period of reactivity. So the second period of reactivity, it's between the second and a half hour to 6 hours of life. So this is the second period of reactivity. So again, at this time, the baby wakes up from the sleep. Baby will start gagging and choking on mucus. So at this stage, it's very normal to see like the baby's trying to bring up a lot of secretions. You can see like parents will be telling the baby is like spitting up more. The baby's having a lot of secretions. They're spitting up more. They're trying to bring up secretions up. So which is called a gagging and choking episode. which is a sign that it's an active stage of second phase of reactivity. So at this stage, again, the baby will be very responsive. Like the baby will be looking around, the baby's eyes will be open. So in both periods of reactivity, the good thing is like their senses are really alert. Like they look around, their eyes are open, they're searching for people. They can follow the colors, especially they follow the red color because they have been inside the tummy and seeing all the red color. So they're so much into the red color. So they can follow the people. They can even listen to the sounds. Like they will turn out to the sounds and see like where the sound is coming from. So all these things. So when the baby go through all these periods of reactivity, that means it's a positive adjustment to the extrauterine life. So this is the best time. So even though we talk a lot about periods of reactivity, when we talk period of reactivity in relation to breastfeeding, it makes a lot of sense to us. So that's the reason we say try to feed the baby within the first hour. That's called early initiation of breastfeeding. That's a first optimal breastfeeding practice that has been put forward by UNICEF and IFPAN. So I think you understand like what's the importance of all that stuff, like why we have to start breastfeeding in the first hour. Because if you don't start breastfeeding in the first hour, you don't get a chance to feed the baby for the next 3 to 4 hours, which is delaying the process of breastfeeding. But again, then comes the second period of reactivity. So that's the first one. Then again, breastfeeding and NICU babies. So with the first, as I said before, it depends upon the scenario. It depends upon like what is going on with the baby. We never know. Delivery is always an unpredictable thing. Some babies will be really good. You will have a full-term baby, but sometimes the baby can come out a little bit on the lower side too. The UPCARs might be low. The respiratory status might be low. Baby might be grunting. Or you might even have like really sick babies, like really tiny preemie babies. So when you get like such babies, some of the babies would be like taken right away to the NICU. Like we don't even get a chance to get the baby to the mommy. We don't get a chance to like put the baby onto the mommy's breast because the moment the baby comes out, the baby will have issues that has to be addressed as soon as possible. So when it happens to have that, how can we do breastfeeding and a sick baby? That's one of the major challenging factors. So with well babies, we can always do everything organic. We can always do everything natural. So when we talk about breastfeeding, most of the people think like breastfeeding comes and it has to be like you feed the baby off of the breast. But there is a different side of it. It's like a part of it. You have to think like breastfeeding is something you can express and you can still give the breast milk to the baby. So that is like you can breastfeed and you can still be doing expression and giving the breast milk to the baby. So it doesn't mean like the mother has to breastfeed like physically. If you can express it out and give it to the milk to the baby, it's still breastfeeding. So you can see over here, when you have a NICU baby, this is your lifesaver, breast pumps. So you have different types of breast pumps available. I can show you some of those, but I really want you to be like a little bit more familiar with the breast pumps. I know we do have breast pumps back in India. But these are the best things you can do for your baby once you have a baby that has been in the NICU. So when the baby is admitted to the NICU, the mommy will have all these emotions because some of the mommies will come with a birthing plan. They will come out, they will say like, okay, I want to breastfeed my baby, but the baby's in NICU. Say for it's a 32-weeker baby and the baby's in NICU. So what the best thing we can do is like you can tell mommy, you can still breastfeed, but what we're going to do is like the baby may not be able to suck onto the breast. The reason is like the breastfeeding is a lot of exhaustion. Like the baby has to like get onto the breast tissue, has to give a good sucking reflexes. That's a lot of pressure. They need to have a good respiratory rate and good heart rate, and they have to be stable so that they can start sucking. So when you have like tiny babies, it's really hard for them to breastfeed because they get exhausted so faster. We cannot do a complete physical breastfeeding. So what happens is like we start pumping. So I have brought a breast pump from our unit. Debardi madam, are you able to see?
Yes, sir.
Okay, so this one is a Medina pump. So this is the breast pump that we use within our unit. And most of over here, pretty much every mommies, they do get a breast pump. Like no matter what, like every people over here, they do have insurance. It's like a mandatory health plan. And even if the people doesn't have insurance, they have a Medicare program, which is like a government funded program. So years before they had to pay for the breast pump, but now it's totally free. With the insurance, they get it for free. So every mommies, they can have a breast pump. They are totally okay with having a breast pump. So this is the breast pump. You can see it. It's got like different parts. There's like tubings that go here. And then this portion, it's a turn on and off button. And this is how you regulate the breast pump. It's very simple. There's like no many more buttons over here. Sorry, it's basically like a power on off button, and this is the one that determines like the pressure at which you can pump. So what we do here is the tubing has like flanges with bottles here, and this will be given to the mommy as soon as possible. So if you have like a tiny baby NICU admission, and when the mommy gets to the floor and she's normal, if she's not in pain, within the first 2 to 3 hours, you give her time for resting and relaxing and rejuvenating. When she feels much better and comfortable, and if she's okay with pumping, you talk to her. You say that, hey, if you want to breastfeed, we can start pumping. And if she's okay with it, if mommy is okay with it, it's a total consent that we have to get from the parent. If the mommy is okay with it, we can start pumping. So this goes into the breast tissue. So what you do is you turn it on, and then this one goes into the breast tissue like that. This portion is called the flange area, and then there's the tubing that gets attached to the pump, and it goes into the breast tissue. You make sure it's a tight seal. So there are different sizes of this. It depends upon the size of the breast of the mommy. Suppose if you have a very tiny one, you get a smaller size of this. Some of the mommies will have big breast tissue, then you get a bigger size of this. But you have to make sure the size of your breast and the size of the flange are compatible. So it goes on over here, and you make sure there is a tight seal. If you don't have a tight seal, the suction won't be appropriate. And then you turn on the button, and then you turn on the regulator, and you can set to the pressure, whichever you feel you're comfortable, because your breast tissue will be pulled in and out. It's a tugging. So your breast tissue, it's like it's pulled in and pulled out, pulled in, pulled out. It's like it's just milking your areola tissue. So you ask mommy to like set the pressure to whichever way she's comfortable. Some of the mommies will feel like, okay, you can go on a high pressure, it's fine. And then they will start pumping. We tell them to pump for at least 15 to 20 minutes. So what you're doing with 15 to 20 minutes is, if the baby was there, the baby will be breastfeeding for 15 to 20 minutes, which is considered as a good breastfeeding time. So we are trying to do the same thing with the pump, because we have to stimulate. So because remember, when I tell about the physiology, the stimulation is the first part that comes, which will help with your brain to sense it and start producing all that hormone. So what we are doing with the pumping is we are giving the same stimulation that the baby should have given. So the hypothalamus can detect it and can signal the pituitary to start producing all the hormones so that milk production can happen. So with the NICU babies, this is what we do. We tell mommies to start pumping at least for 15 to 20 minutes on both breasts. So you can, when you have a breast pump, you can do pumping on both sides of your breast simultaneously at the same time. Some of the mommies like to do one side at a time, and then she likes to do the second one another time. That's fine. It's totally up to them. If they can do two at the same time, it's fine. Or then if they can complete one and do another one too. We have like supporting bras which they can use, so their hands are free. Their supporting bras, it's special fitted under dresses. They can, which will hold the pump in place. So if mommy wants to like do something else, she has their hands free onto. In the second picture, what you see, it's called a manual hand pump. So the one you saw right now, that's an electric pump. So it gets hooked up to the electricity. It's really high pressure pump for a good stimulation. But if some of the mommies, they don't really want to do electric pump with so much of pressure, they just want to do a very minimal pumping session. This is called a manual pump. So manual pump is like, if there's like no electricity, nothing, it's very simple, it's handy. You can always carry it on your back. Even though this pump looks a little bit bigger for you, we have tinier versions you can always carry in your bag. The very small ones which you can carry in the hand. So this one is the manual pump. So it's the same process again. You have the breast tissue, it goes onto the breast tissue, and then you see this portion. This is how you will start pumping. So that's called manual pumping. So you don't hook it. It doesn't have that much of a pressure, but it still helps with expressing the milk out of the mommy's breast. So either way, we are just giving the stimulation. So in the picture, you can see something on the third one, a light bluish one. Those are portable pumping ones. So those mommies who are working, because some of the mommies will start working immediately after giving birth, like in 6 weeks after having a baby, they might start working. So for those mommies, for convenience, you have portable pumps. So those are portable. What you can do is like you can put it inside your clothes, and then it will just go onto your breast tissue on both sides. You don't have to do anything. You can put your clothes back on, and you can go for work. It will keep pumping inside. And then once you see the tiny reservoir down there, like the tiny bottles down there, when it gets full, you get a message on your phone or you get a message on your watch saying your milking session or your pumping session is complete. It's a little bit more of the technology side, but still it has been like used by many women over here. So these are the types of pumping which can be utilized when you have a very small NICU babies. So NICU babies, it's still breastfeeding, but the only thing we are doing is like we are expressing the milk and then we are giving it to the baby. So either way, like it doesn't matter. Like some of the mommies think like breastfeeding is just like you feed the baby to your breast, but you always have to talk to them saying like it's not breastfeeding is not really like doing physically, but you can always what matters is like you get the breast milk to the baby. That's what that makes the difference. Even though the bonding might lag, but the best thing for you're trying to give the best possible thing for the baby. So the best possible thing is like you get the breast milk and you get it to the baby, so the baby can have built up all this immunity and they can have their brain develop much faster. And even when you have a preterm baby, the best thing your body is doing is like they customize the milk, because when you have a preterm baby, your body knows you had a very tiny one, so your milk will have higher amount of nutrients. It will be more thicker, more concentrated, which will supplement the demands of a preterm baby. So that's the reason it's called very magical, because when you compare a breast milk of a normal term baby, mom that produced breast milk and a mom that produced a preterm baby breast milk, the breast milk components very vast and very majorly, because those breast milk which has like a preterm baby milk, it will have higher amount of nutrients and calories and antibodies and all that stuff that will make sure that supplements and caters for the need of a preterm. So your body specifically makes this breast milk to the needs of your baby. So this is about that's about the breastfeeding and NICU baby. So that's about pumping. Pumping is a major thing. It looks a little bit more complicated, but it's very simple and it's such a lifesaver for your baby. What are the challenges of early initiation? So early initiation is the first step, but we definitely will come across with the challenges of early initiation. Some of the challenges would be the first thing is like sick babies and preterm babies needing respiratory support. So, some of the babies which comes out with respiratory support, like say for it wasn't planned. The other day we had a COVID mom and wasn't really doing good. So we have to do a C-section, get the baby out. Like sometimes it happens, like when the baby mommies are not stable. There were like years back, we had a mom who had a seizure when she was just like 30 weeker, 31 weeker. She went into like active wheezing. There was like no history. Everything was good, doing good, and all of a sudden she started having the seizures, which can never stop. She kept seizing for almost like 2 minutes, and then if they call for a stat C-section, so they would do that. They can take the baby out. They're making sure everything is fine with the baby, because they always go with the best possible case. Like if the seizure goes on, then it's definitely going to harm the baby, because a lot of seizing can cause like neurological deficits. So what they do is like the moment they'll do a C-section, they'll take the baby out, they'll settle the baby. They'll take a 30 weeker, definitely needs a lot of respiratory support. But what they do is like they take the baby out, they can intubate the baby, stabilize the baby, they put the baby mommy in a ICU and settle her. So they make sure both the lives are stable. And then there are some of the cases we call it's called mommy's going to cold blue, like there's nothing else we can be done, and then the baby will be taken out through a C-section. So all these cases, what we do is like if we expect, suppose if we have a 32 weeker or 33 weeker and we expect she's going to deliver preterm, betamethasone will be given. The steroids will be given so their lungs become more matured. But in cases like nothing can be given, the babies go straight into respiratory support. So this is the thing. When they go to respiratory support, when they're tiny, they will have an NG tube or they will have an OG tube, which will be used for feeding the baby. They may have IV supports. They may be on ventilator. There may be too many things going on. So what we do is we would start pumping for the baby. So that's one challenge. So the sick babies and preterm baby challenging can be addressed by proper pumping. So you tell mommies to pump every 2 to 3 hours. That's the best stimulation for your breast tissue. That's the best stimulation. So your brain will start identifying it as a need and will start supplying. So the breastfeeding and milk production, it's like a demand and supply. The more the demand, the more the supply. So the demand is created. So how do we create the demand? If it's a normal newborn, the baby starts sucking, that's a demand. That will be expressed as a demand to the brain and the brain will start supplying. But if the baby is not there, then we create the demand by pumping. So the more they pump, the more the demand, and the brain will start supplying more. So it's a demand and supply. So it's a very well balance of demand and supply. So suppose if the mommy doesn't breastfeed the baby, the mommy doesn't do pumping, what happens is there is no demand. So your brain will be okay, seems like there is no demand. We don't have that. We don't need that many hormones. So your breast milk supply will go on the lower side. Second one is the flat nipple. That's one of the other challenges with early initiation. Some of the mommies will come in. They might not have a good areolar tissue, good nipple size. So what happens is they have a very flat nipple. So when we have a flat nipple or an inverted nipple, so the inverted nipple is the nipple is literally it's pulled back in, or a flat nipple is literally there's no plunging out. So what happens is a flat and an inverted nipple, the baby finds it really hard to latch on, because once you have a good nipple, it's a good latch and the baby can stay over there. Baby has a good hold. But when you don't have a good nipple, and if it's a flat nipple, you don't have, what happens is the baby has trouble latching on. There's if the baby will be trying harder, but the baby couldn't latch on to the mommy. So what we use for that, I don't know if you can see this one. This is called nipple shield. Can you see this one?
Yes.
Okay, so this is a nipple shield. So what you do is it goes on top of mommy's nipple like that. So it's an artificial nipple created. So you see, if mommy doesn't have a nipple, we have this nipple shield. It has different sizes depending upon mommy's breast tissue. It goes on top of mommy's nipple over here, and then it creates a strong suction. When it creates a strong suction, it will be placed there, and now the babies can latch on top of it. So when the baby latches on, the baby can have a good hold of it. So the baby latches onto the shield over here. The baby latches on. When the baby starts sucking, it creates a negative pressure, because over here it's a good dome. It creates a negative pressure that will start expressing the milk from the mommy's breast tissue. So this is called a nipple shield. So the nipple shield is the best thing when you can use when you have a flat nipple or an inverted nipple. I was googling to see if you have it back in India. Some of the hospitals they show it there in Amazon too. But this is called a nipple shield, which is used for flat nipples or inverted nipples. That's one of the other challenges. So this is how we encounter this challenge. The third one is postpartum hemorrhage and complications following delivery. So postpartum hemorrhage is something that can happen 1 in 50 deliveries, 1 in 100 deliveries. Sometimes there can be a chance of postpartum hemorrhage. So hemorrhage is something when you have a normal vaginal delivery with a blood loss of greater than 500 ml to 750, then it's on the mild side of a hemorrhage. But we get sometimes with C-section, sometimes they can lose up to 1,250. But anytime when they lose greater than 1,000, it's technically called a hemorrhage. But your body can compensate for it. If it's 1,000 ml or 1,100 ml, the body compensates for it. But when it gets to the point you lose half of your blood volume, therefore you lose 2.5 liters. You have 4 to 5 liters of blood in your body. You lose 2 liters to 2.5 liters of blood. It's called postpartum hemorrhage. So what happens is a major volume depletion happens. A major volume of your blood is just lost out of hemorrhage. All of a sudden, I remember Muthalakshmi madam explaining about DIC one time. Ma'am came for a class and then ma'am explained, like, do you know what DIC is? It just came into my mind. So when massive hemorrhage happens, this huge blood loss, what happens is like the body will go into a compensatory mechanism. So what does it mean by a compensatory mechanism? What happens is like your body realizes there's a huge volume depletion. So the body will start shunting and it will start giving blood only to the major vital organs. So the body will cut down supply to the rest of the areas. Like the pituitary body will give like very minimal blood to the pituitary glands, but the body will start supplying more to kidneys and liver and lungs and heart and brain. So body will try to like supplement all the vital organs, and it will kind of like shut down on the tiny little organs, which doesn't have major impact on us for now. So this is called a compensatory mechanism. So what happens in a postpartum hemorrhage is it affects the breastfeeding. How it affects the breastfeeding is like when the body goes into the compensatory mechanism, the pituitary glands doesn't get enough blood. When the pituitary glands doesn't get enough blood, all the hormone activation doesn't happen because the pituitary is not getting enough blood. The pituitary is the one that supplements the production of oxytocin and pitocin. So all that hormonal balance is just gone. So when you have a mom who went through postpartum hemorrhage, it will take a longer time for them to establish the breastfeeding. So when you have a postpartum hemorrhage mom, you might have to explain because mommy's colostrum will be very low. Mommy's breast milk, usually the breast milk, the colostrum will be good for they will be coming in the first 24 hours. And then you will have the colostrum for the first 2 to 3 days. And from the 3rd to 4th and 5th day, you have the breast milk come in. So that's a normal process. So the first 3 days is just the colostrum and then the breast milk will follow. And usually by the 5th day, you will have a full supply of breast milk. That's a normal process with the breastfeeding. But with the hemorrhage mommy, you have to explain to them, you have to inform them, this is what happened. You had a hemorrhage and you had a compensatory mechanism. It will take longer because we need to replenish the fluids and we have to bring back the balance. So we have to make sure the mommy gets like enough fluids. We have to talk her about hydration, better food and supplementing and all that stuff. So that's one of the major challenges when you have a postpartum hemorrhage mommy. And again, one of the other challenges with early initiation is instrumental or prolonged labor, causing exhaustion to the newborn. Because when it's an instrumental labor, suppose the baby has been stuck there for a long time, mommy was on labor for like 24 plus hours, the baby comes out like really tired. They are like they don't want to breastfeed. They go into very long sleeping episodes. They may not eat for a long time. Sometimes we do have twins which come out the same way because twin delivery can be a little bit prolonged and they stay there for a long time. They don't want to eat. So when babies have like kiwi deliveries or maybe like instrumental deliveries, when we have to use all that things, we have to expect the babies might have challenges with early initiation. So we have to be a little bit more like actively trying to like help them with the feeding. And some of the babies, they come out with physiological factors called cleft lip and cleft palate, which definitely will have an impact on breastfeeding. So that's definitely one of the other challenges of early initiation. So when the baby has a cleft lip, cleft palate, we might have learned about tracheoesophageal fistula. So all those are like the normal physiological factors which can have a very negative effect on the early initiation. And some of the mommies will have breast surgeries, like mastectomy. They have a breast cancer. They don't have one of the sites might have been like they have undergone mastectomy. And then it's a very common procedure nowadays to have breast augmentation and breast reduction surgery. Some of them might be for cosmetic purposes, some of them for the medical reasons too. But anytime when you have breast surgeries done, it definitely has an impact on breastfeeding too. It's not like 100% it's impacted, but most of the mummies, they do have trouble with breastfeeding once they go through breast augmentation. It's so once it gets augmented, what happens is like it interferes with your mammary glands, and then the breast milk production won't be that accurate. The baby will have trouble latching on. The mommy will have trouble producing the milk. And sometimes they go for reductions, and it's the same thing too. So when these are the major challenges of early initiation of breastfeeding, like sick babies, flat nipples. Some of the challenges as they really try other interventions to make sure like the babies get adequate breast milk. But the problem with the other, say for cleft lip and cleft palate, definitely you can start pumping and giving it to the baby. But the cleft lip and cleft palate is like, it's the problem is like the baby don't get a good latch on. They don't have enough suction because they do have a palate or a lip which is like incompetent. So what we have to do is like we have to start doing pumping and then we can give it to the baby. So pumping is like one of the efficacy measures for most of the challenges. With instrument lamp prong labor and breast surgeries, it's definitely something you can start pumping, but definitely it do have an impact on breastfeeding and initiation. How to encourage breastfeeding? That's one of the other things. How to encourage? What are the things we can do for encouraging the breastfeeding? The first and foremost thing we can do for encouraging breastfeeding is first hourly feeding. That's something we have been talking for almost the past 20 minutes. The second thing is rooming in. Rooming in and kangaroo mother care. They both come in hand in hand. So kangaroo mother care, or we call it kangaroo mother care. So that one, which means like the baby, you can see the picture over here on your right hand side. So the baby is put onto the mommy's chest as soon as possible, and they can hold the baby in this position as long as they're willing to. If the baby is comfortable, if the mommy is comfortable, they can do kangaroo mother care for as much as possible. It's called kangaroo mother care. And rooming in is like you keep the mommy and the baby in the same room as much as possible. You try not to separate them. So if you're doing any procedures, whatever it is, like you try not to separate them. You keep them together. And then kangaroo mother care, there are too many benefits of kangaroo. Just like breastfeeding is, there are too many benefits of kangaroo mother care. The position for kangaroo mother care you can see over here. It's like the baby's just will be resting the between the mommy's breast tissue and the legs will be folded. It's like a frog-like position. Like it's all like cuddled up, frog-like position. It's called kangaroo mother care. There are like multiple benefits with kangaroo mother care. The benefits for the baby are like it helps with their temperature regulation. Suppose if you have like tiny babies, they have temperature issues, hypothermia. You can always put the baby on kangaroo mother care. So the reason is like it stabilizes the body temperature of the baby. It helps with better breastfeeding because the more the baby is close to the mommy, the baby can smell the colostrum. As I said before, the breast tissue, which has the same smell of the amniotic fluid, which produces the colostrum. The baby is really in close contact with the breast tissue, so the baby can smell it. When the baby smell it, it's just like we smell food, we feel hungry. You know, like you are sitting somewhere and you start smelling really delicious food and you feel hungry. It's the same way. The baby smells food, the baby feels hungry, they will start crawling towards the areolar tissue so they can latch on. So, and then one of the other benefits is like the baby's heart rate and respiratory rates get much stable. They cry less. That's one of the other things. Their fussiness and they will be much reduced. They are more relaxed. The reason for the relaxation is like the moment you put the baby to the chest, it takes them a minute to settle down. But once they settle down, they can hear the heartbeat of the mommy. They can smell mommy. They can hear the heartbeat. They can smell the colostrum. So when they hear the heartbeat is something they have been hearing for 9 months, which they're used to hearing for a long time. That relaxes the baby. And again, we can do demand feeding and time feeding. So how to, before we are going into demand feeding, the benefits for mommy with kangaroo mother care is like, the first thing is like it helps with the bonding for mommy. It helps with her postpartum depression. It helps with relaxing the mommy. And if mommy has issues with blood pressure, with pain, it has proven that the blood pressure and the pain of the mommy has come to a reduced level when they put the baby skin to skin. We have had here like mommies who have like real bad anxiety. They go into like anxious episodes. Sometimes they will be like very nervous, but once they put the baby to their chest, they feel like more relaxed and more calm. So there are too many benefits of KMC. We call it KMC, but it's kangaroo mother care. And then, so one of the other things we teach them is about breastfeeding is demand feeding and time feeding. So there is a difference between demand feeding and time feeding. So demand feeding is like you tell these are the things you especially would be focusing when you have a first time mommy, because when you have a first time tiny mommy, they have very limited knowledge. Like it doesn't matter like if they are educated, if which social status they come from, whatever it is, they have very minimal knowledge about breastfeeding. So you have to like teach them anything and everything about breastfeeding, like what breastfeeding is, why do we do breastfeeding, what are the things we have to do in breastfeeding. So demand feeding is like, usually parents would ask you, how often do I feed the baby? That's a big question. So you can tell them, so you will be feeding the baby every 2 hours if it's breastfeeding. You'll be doing it every 2 hours. The reason for every 2 hour breastfeeding is they have a very small stomach capacity. So because they have a very small stomach capacity, once they pee or once they poop, everything is gone. And now we have to refill it again. So so the first day the stomach capacity is like 8 to 15 ml. That's what we usually say. And then it starts getting to like a 20, 25 ml second day, and third day is like 30 ml, 1 ounce. But the first day is like very tiny. They have a very tiny stomach. So what we tell them is like, okay, this is the stomach capacity of the child. So timed feeding is like you tell the parent every 2 to 3 hours. Usually we say 2 hours. But be timing. Sometimes they would call and say, hey, I fed baby at 8, and by like 9, this baby is so hungry. We are seeing all these cues. It's called hunger cues. The baby's like opening them all wide open, searching for food, and it's trying to latch on, sucking on the fist, which are all the hunger cues of baby showing, saying like, I need food. So when a baby's fed at 8, and then when the baby starts looking for food at 9, the parents would wonder, see, I timed the feeding for 2 to 3 hours. Why does this baby start having hunger cues in an hour? The reason might be the baby might had a big pee or a poopy diaper. Now the baby is all empty. The stomach is empty. It's all emptied out. Now it's time for demand feeding. So it's demand feeding is like whenever needed, whenever the baby needs it. Whenever you see the hunger cues, you feed the baby. That's called demand feeding. So the best technique of breastfeeding, it's a combination of time feeding with demand feeding. That's the best thing that's going to benefit for a child with breastfeeding. So when they come to you, you tell them time feeding with a combination of demand feeding would be the best would be the best strategy when it comes to breastfeeding. So demand feeding is like whenever the baby's tissue. So no matter what. So maybe you have done feeding for 30 minutes and you just put the baby there. It's been only like an hour, a couple of hours, and now the baby starts feeling hungry again. It doesn't matter the demands of the child. That's called demand feeding. One of the other things to encourage breastfeeding is no use of teats or pacifiers. So pacifiers are like no nutritive sucking. They don't definitely benefit anything out of it. It has been a very common practice everywhere, universally, that we provide pacifiers when the baby starts crying. So we usually tell mommies like try not to use the pacifiers. The reason is like pacifier, like it kind of like soothes the baby because you see hunger cues, mommy is tired, doesn't want to breastfeed, and the baby is showing and exhibiting all these hunger cues. You give a pacifier to the child. It's non-nutritive sucking. They're not benefiting anything from that. You can see the baby's actively like sucking on it. And what happens is like the more they start keeping sucking and sucking, they are just getting tired and they get frustrated. So they're not benefiting anything out of it. So we usually tell mommies like try to lessen. We cannot tell them like no to use that, but we would tell them like if they could substitute the pacifier with the breast tissue. If they can do breastfeeding instead of doing a pacifier, it's definitely going to benefit them. How it's going to benefit is like the more instead of the pacifier, the more the breast tissue goes into the baby's mouth. That's more of a stimulation for the breast tissue. So the more the stimulation, the better will be your milk production too. So you can always educate them because sometimes they just give the pacifier, they don't think the other side of it. So when we talk and explain stuff, they're telling, hey, if you do the breastfeeding and stop pacifying, your breast milk will come in faster. You will have more breast milk because it's more sucking, more stimulation, more breast milk. So most of the parents will understand better with that too. The position of breastfeeding, back in India, we always have seen like the cross cradle hold for positioning for breastfeeding. So that's like the technical normal cross cradle. You put the baby on your arms, the head will be supported on your arms, and the baby will be going onto the breast tissue. But mommies, they can do any positions that's hours. So the problem is like it's a little bit more painful to like sit up onto a sitting position and feed the baby. So that can interfere with breastfeeding. So you can kind of like show them different positions of breastfeeding. One of the major positions is called football hold, which has been shown like wonderful with C-section mommies. So with C-section mommies, with the football hold, it's like the mommy can be on a semi-lying position. So she doesn't have to like sit up, because the moment she sits up, her incision gets hurt more. You can tell her you can still lie down. You can be in a 30-degree, 45-degree angle, but we usually try to put them at least to a 30-degree angle headwise, and then you put the baby facing the breast. So instead of doing a cross cradle, what you do is like if this is the baby, say for if this is the baby, you take the baby, you hold the head, and then you hold the body between your arm and your body, and then you put the baby facing the breast like that. So you don't have to like sit down. The baby will be facing the breast. So instead of doing a cross cradle, which the baby goes across the tummy, the baby is not going across the tummy. So it's less painful for a C-section mommy, and the baby will be facing more onto the breast tissue. So that's like, you can teach them like different positioning techniques, like cross cradle, you have cradle hold, cross cradle hold, football hold. So all these positions can definitely make an impact on improving the breastfeeding practices. It depends upon like what kind of delivery they went through, what they want to do. It depends upon the comfort level of mommy too. And again, the nutrition aspect, it's a big topic of discussion. Nutrition is like one of the major things. You have many superfoods, which is believed to make like wonderful changes in breastfeeding. So we always tell mommies, like, no matter what, they can be vegan, they can be vegetarian, they can be non-vegetarian. You can tell them like what are the best nutritional practices they have to follow, so that they can have a better breast milk production. So we always tell them about the balanced diet, which is a combination of carbohydrates and proteins and legumes and all that stuff. So you can tell a well-balanced diet is the one that's gonna produce much better breast milk, because breast milk, when you don't have a balanced diet, it's more like water content than nutritive wise. But when you start having a well-balanced diet, nutritive wise, it's really helpful because it helps with enhancing the nutrition. It is packed with more of like antibodies and nutrients and whatever which is oligosaccharides and whatever which is needed for the baby, it gets passed on to the breast milk. So we usually, the superfoods, usually we tell them about like eating, if it's like a non-vegetarian diet, like beef and egg and green leafy vegetables. So whatever like it's available. Again, it's a cultural and thing too, because some parts of the people, like it's a cultural practice, they don't eat meat or any of the non-vegetarian things for a certain period of time once they have the babies. And again, like some of the people will stick on to like more non-vegetarian and vegan diet after they have the baby. So it's a cultural thing too. So you have to incorporate what culture they belong to and what backgrounds they belong to before we educate. We can always consult a dietary consultation, so they can come and explain, and they can make customized decisions about the nutrition aspects of the parents. But we always tell them, we explain in a very simple way, like you try for a balanced nutrition, like whatever they are eating, try to balance between the carbohydrates and nutrients and the carbohydrates and proteins and fat and all that stuff. And supplements. Some of the we have seen a lot of supplements now. They've started doing supplementation that enhances the breast milk production. One of the major things, this was very interesting for me. Back in the days when Aaron was born, Aaron is my son. He's 5-year-old right now. So when Aaron was born, my mother came from India. So from India, like, it's a cultural thing. You prepare food with fenugreek, which enhances the milk production. So she prepared like good stuff, really like porridge consistency stuff with fenugreek. And it has like really helped me. Like in a day or two, you can see a big change in your milk production, quality-wise. Quality and quality-wise was like more thicker. You have a full burst of milk, and it has enhanced my milk production so much. So fenugreek was something I thought like it's a part of the culture, and I never thought much into it. Like I had it for some days, and my milk production was better, and it was helped me immensely. And then we had back in Michigan, when we used to live there, we had like a lot of Tamil culture people around us, and they used to have the same thing. Fenugreek was like one of the major ingredients into their diet, and especially when they have a baby and breastfeeding. So we always used to tell like how amazing is the culture back from India. You have fenugreek to help with breastfeeding. It's such a major change. Like it's bringing so much effect into breastfeeding. And then when I happened to have attend one of the lactation classes over here, they started talking. It's the people over here talking about Native American people. They started talking about fenugreek. It literally amazed me. Like an American man, like a woman talking about fenugreek in a big lactation consultation class. So these it's research proven fenugreek is one of the major ingredients that can help with milk production. So see, it's not a cultural thing; it's a research proven thing. The fenugreek that we use as a part of our culture, it has been proven to enhance the milk production in mommies. So over here, we use fenugreek for the normal cooking practices. People over here, their food pattern is a little different. So what they do is they have tiny fenugreek tablets. It's called organic fenugreek tablets. It's organic, very tiny. They get it as a capsule. Even they do turmeric. I'm more like manjal related. Even turmeric, they get it as tiny capsule tablets. They take turmeric and fenugreek as tablets. They get it in the stores, and they take that for enhanced breast milk production. So, and there is something called Mother's Tea. It's a tiny green tea sachet. They put it in hot water, and it's called Mother's Tea. It helps with the lactation. It helps with improving the breast milk of mommies. So the Mother's Tea, even though the sachet says Mother's Tea, when we check on the components, the prime component is fenugreek. So that's one of the major supplements. I really want to bring this up in the topic over here. So fenugreek is like one of the wonderful major component that helps with the breast milk production. And again, the last and the foremost important thing is hydration. We usually tell mommies like breast milk, when you start pumping, you have to make sure you drink a lot of water. So at least like if you're drinking, the studies usually have projected out saying you have to add whatever you are drinking. Say if you drink like 3 liters of water a day, you have to add at least like a liter to liter and a half when you start breastfeeding. So if you're drinking 3 liters before breastfeeding, you have to add like a liter. So make it like 4 to 4.5 liters. So you have to add more hydration status onto your patterns when you start breastfeeding, because a major component of breast milk is water. So the more you keep yourself hydrated, the better will be the milk production. So this is the first aspect. So it's the first and foremost optimal thing is like early initiation of breastfeeding, and then the second thing is like continuing with the breastfeeding or exclusive breastfeeding for 6 months. So that's all the things which I just covered right now. So the first thing will be like you do breastfeeding, you initiate the breastfeeding, and whatever you initiated, you continue it for 6 months. So this is the major aspect of the major second aspect of optimal breastfeeding practices, exclusive breastfeeding up to 6 months of age. Years back, I remember when I was a PG student, we were doing sessions saying like there was a tiny revision. I know, like I think 15 years back it was like 6 months, and then they revised saying 4 months. Now we are back to 6 months again. So we say exclusive breastfeeding for 6 months of age. No water, no sugar, nothing. Like the only thing that goes into the baby's mouth will be breast milk, and there's nothing else that has to or that should go into the baby's mouth. The only thing is breast milk. I know in some culture, we have a multicultural system over here. We get people from different parts of the world. We get like Jordan people, Lebanon people, Middle East, and then we get like a Canadian, like different parts of the world. They have different cultures. Some of the people have the culture of giving water, like plain organic water to the child, but no. When it comes to exclusive breastfeeding, no water, no passive, no sugar, nothing. The only thing that goes into the baby's mouth should be breast milk. So we tell mommies, we educate them. The baby has to be breastfed at least for an age of 6 months, for their brain development, for their immunity, for the enhancement of every single organ in their body, for all their systems to develop, for the neurological and all the systems. And then comes the third major component of optimal breast practice. It's called supplementing safe and adequate complementary foods. So once it comes to 6 months of age, then we can start supplementing the complementary foods. So it's up to their cultural practices. You can give puree foods. Over here, it's like you make carrot puree. Whatever it's supplementing is like you start slowly, but you start introducing whatever your cultural foods are, like whatever you are used to eating. You slowly would start like in a mash one, and then you go into your regular pattern of it. So you start introducing complementary foods or supplementary foods after 6 months of age. But the major aspect when you start supplementing is like you teach your parents you have to proceed with supplementing. At least you can go up till 2 years of age. But I usually tell them at least if they can go up to like an year of 1 year of age, that would be the best thing to do. But at least you can do up to 2 years. But 1 year would be the best thing. But if you can do the 2 year thing, that would be awesome. So you can so the first thing would be early initiation of breastfeeding. Second thing would be you make sure it's being carried out for the next 6 months, and then the third thing would be you are supplementing and making sure you're giving the complementary foods to the baby. You're introducing all the food, and then you breastfeed. That's again and again, breastfeeding comes with everything. So you breastfeed along with supplementing till 2 years of age. So 2 years is said to be the normal aging pattern for the baby to breastfeed, but at least till 1 year, that would be the best thing. And now the international baby, so that's I'm just summing up everything. Optimal breastfeeding practices. So you do early initiation, exclusive breastfeeding until 6 months of age, and continued breastfeeding up to 2 years of age and beyond, along with timely introduction of safe and adequate complementary food. So these are the three things which we do as which has been proposed by IPAN and UNICEF. So those are the major breastfeeding practices which we have to do, which we have been talking for 45 minutes right now. I'm just summing up everything. So these are the major things: early initiation, exclusive breastfeeding, and then continued breastfeeding till 2 years of age. So the global strategy for infant and child breastfeeding, it's again saying the same thing about exclusive breastfeeding. And evidence indicates that interventions to promote and support breastfeeding. So once you start supporting and promoting, so how do we support and promote? Supporting and promoting is usually done through the IEC model. So that's information, education, and communication model. So you provide more information, you start educating the people. When you start educating, it's enlightening. You are enhancing the knowledge and making sure people are adequately informed about breastfeeding thing. Because some of the mommies, like when they're first time mommies, they have no idea what breastfeeding is. So it's our duty. Like you teach them, you educate them, like what breastfeeding is, what are the techniques of breastfeeding, why do you breastfeed? That's a big question. They never might have thought about it. The why for breastfeeding is a major thing. That has to be done. So interventions are formal breastfeeding education for mothers and families. So the formal breastfeeding practices, it has to be started even before delivery, because after delivery, if they go through all this, they are in pain, they're going through hormonal changes. So effective breastfeeding practices has to be started even before the delivery. So when they go for the antenatal checkups, the doctors and then the support people over there might be lactation consultants, there might be doctors. Over here, there's something called breastfeeding classes or lactation classes. They can enroll to it. It's pretty much like free classes. The parents can enroll to it. They go for the classes. They get to know what breastfeeding is even before the baby is delivered. That would be a really good thing to do everywhere, because people get to know what breastfeeding is and why they have to do breastfeeding and what are the techniques before the baby comes to the world. And direct support of mothers during breastfeeding, good support system, training of primary care staff about breastfeeding and techniques of breastfeeding, and peer support. Peer support is a major factor. We have peer support groups over here. It's a group of mothers who breastfeed. They come together and they support the new moms. So what they do is like basically when you're at the hospital, they will give you all the information about the peer support. You can enroll, you can just text them, and then you will have a mother who breastfeeds and who has a better idea about breastfeeding. They will call you at least like once a week or twice a week, or they will give you an information thing. They will give you their contact saying like, hey, you can call me, because breastfeeding can be a little bit it's stressful at times because parents are not sure what to do. They don't know if they're doing the right thing. Even when I was breastfeeding Aaron, I always had this question: is he getting adequate? We never know, because once you're breastfeeding, you have no idea how much is this baby getting. You are always questioning, like, am I doing it right? Is the baby getting anything? Is the baby okay? Is the baby fed adequately? There's always 1,000 questions in your mind. So peer support and peer groups are really supportive, because they are the people, they come, they close contact with mothers, and they talk. They can talk about anything. They can ask questions. They will show you. They FaceTime. They support you. They answer your questions. Those are wonderful groups. So peer support groups are really effective once it comes into breastfeeding. There's a system framework. It's called Protect Breastfeeding, Promote Breastfeeding, and Support Breastfeeding. So the Protect framework, so protection, promotion, and support of early initiation of breastfeeding and exclusive breastfeeding until 6 months, and continued breastfeeding until 2 years of age. That's basically protecting. So for breastfeeding protection, what are the things we can do to protect the breastfeeding? The first thing we can do is like regulate the marketing of breast milk substitutes. So over here, we do have supplements, but it's very restricted. Like, you can get a formula feeding or supplements, but it has to be like, you should have a medical, there should be a medical need or a necessity to start supplementing. So we need to have some kind of like a law which can regulate the substitution of breast milk. Like, you can say, like, it shouldn't be like readily accessible. It shouldn't be like readily, like, it can be like economical, but still it shouldn't be like readily available, because when parents have a question, it shouldn't be like an option. They can go and get as soon as possible. And then we need to have like a regulation on like feeding bottles and pacifiers and teas. We should have a closed system monitoring who deter for the violators. If you have like violations happening, you always keep an eye on that. And then maternity leaves are one of the major things which has to be like really taken into consideration, because once you're working mommies, it's a full-time job when you're working, but breastfeeding and being a mother is another full-time job. So you are trying to incorporate 2 full-time jobs into one person. So you need to have like the maternity leave. Usually they say like a 12 to 14 weeks, but government has been like recommending at least 18 weeks free. So mothers can have a total quality time. They can breastfeed, they can be with the baby, they can bond. Because some of the mommies will be stressed when they have to get back to work. Like, say for a 6-week period, like, they get like worried. Like 6 weeks is like you're barely like getting to board and breastfeed and all that stuff. So an extended period of 14, 18 weeks, that is something we can do. Like, legislative wise, they can put forward like more agendas so that we can protect breastfeeding. Because once they start working, there's always a chance that the breastfeeding episodes or the breastfeeding practices can go on the downhill. Childcare and breastfeeding facilities in the workplace. So that's one of the major things. Once you start working, you need to have a workplace that can incorporate your breastfeeding needs. You should have break rooms. You should have breaks. Like, you get like a good 20 or 30-minute break at least 2 or 3 times a day, so you can go pump and save it for the baby. Because once you start working, you still have to pump to keep up with your milk production, because if you don't start pumping or pumping, the demands are going lower. When the demand goes lower, the supply will go on the lower side. So you have to make sure when you're working, when you're a full-time mom, your workspace should have facilities, whereas break rooms, we have lactation rooms over here, which has like, you have areas where you can wash your hands. You have a refrigerator, you can pump the milk and store. You need to have like a comfortable chair or a bed where you can start pumping. And you need to have like all the supplies, which is essential for pumping. So when you have a workspace, even if you're working in a college, say you're working in a college, you're working in a hospital, wherever the workplace is, you need to have a room, which is called as a lactation room, which can help you, which can incorporate all the demands that you need for breastfeeding when you're working. So working doesn't mean like you are compromising on breastfeeding. Working has to incorporate your needs of breastfeeding as well. And then breastfeeding promotion, ensure promotion of breastfeeding through information, education, and communication. Develop specific information campaigns and the risks of not breastfeeding. And especially yesterday when Shamla madam was telling about like the higher risk of like infant mortality rates, diarrhea rates, pneumonia rates, sudden infant death syndromes, the the public, the general people may not be aware about like what are the risk factors of not breastfeeding your kids. So you can always like give education session to the public. You can do campaigns, you can do pamphlets, you can somehow you get this information. It's called the IEC model, and you might have gone through that, the information education communication system model that can definitely bring out the best benefits for enhancing the breastfeeding. And then breastfeeding support groups. That's something we have been talking about. Like you have people, you have lactation consultants that come in and they talk, we go through all these classes during the antenatal period. Some of the hospitals, they are said to be BFHI, that's Breastfeeding Hospital Initiative. So everywhere you can see the 10 steps for successful breastfeeding. So what I mean, which is like having best support groups. So having a better support group is like one of the other things which can protect and promote breastfeeding. Lactation consultants are over here. It's like a specialized course. It's still nurses, but you need to work as a NICU nurse in a NICU or a close well baby nurse for at least 5 years to be a lactation consultant. So once you have a good 5-year experience, you can apply for a certification examination, and once you clear the certification examination, you can work as a lactation consultant. So lactation consultants are like they go from they educate, they do this brunch sessions. That's like you can bring, even if you get discharged from the hospital, you can come in like once a week for a brunch. Like it's between the breakfast and the lunchtime, they gather together. They have this sessions of evaluating and making sure everything is good. They check on your baby, they check on how you're breastfeeding, they will evaluate your latching and you will evaluate your breastfeeding. So the lactation consultants are like excellent resources. They are like, they have got like immense techniques. They have a solution for each and everything, like whether it be cracked nipples, whether it be inverted nipples or whatever it is, the lactation consultants are the best people that can help with the breastfeeding. And then finally, so this is all about like breastfeeding, optimal breastfeeding practices. Coming on to the last session, it's about breastfeeding and COVID. So we have been, this is a pandemic, like we have been going through this COVID for almost, I would say like a year and a half, getting close to 2 years right now. And nothing can compromise breastfeeding. At one point, when we started having COVID positive mummies, we were so much worried about babies. We were like, can the baby stay with mommy, or do we have to separate the baby? What if the baby gets positive from COVID? There were like a lot of questions coming around with COVID, because COVID was like all new to us. We had like no idea what COVID is, like how it's transmitted, and what's the side effects, which the researchers are still going on. But fine, it has come on to a point like no matter what, even if it's a COVID positive mommy, baby will be still breastfeeding. So it's the same precautionary measures we take. Like you put your mask on, you wash your hands, and you make sure everything is fine. You still will be giving and breastfeeding the baby. The recent studies, with the vaccines that has come and evolved right now, the two of the major vaccines, which are we have three of the major vaccines which we have over here right now. It's a Pfizer. And we do have Moderna, and we have Johnson & Johnson. At one time, we had a little bit pullback on we were giving more on Pfizer and Moderna. The Johnson & Johnson, it's coming back again at this point. So we have all these three major vaccines which have been given to all the mommies, but we weren't sure they were in any research initially whether pregnant mommies can get vaccines. It was a topic of our discussion, like whether to give it, whether not to give it. But they have come on to a good final decision. Those mommies who are pregnant can have the COVID vaccine. So second trimester and third trimester mommies are getting COVID vaccines right now. And then the pair, 3 or 4, I would say like 5 months back, they were kind of like, if you want to get it, you can have the COVID vaccine. But now with the Delta variant and with the COVID cases going on the higher side, we are having a spike of cases right now, and it's another wave that's coming in. So the doctors have been educating antenatal mothers, especially on the second and third trimester. They are not saying anything about the first trimester. The first trimester is definitely a keep aside thing. So they are saying, okay, you can go ahead and have your COVID vaccine when you're on your second and third trimester, because the good thing is, like, we don't have, even though I want to share this information, I want to say something else to you. We don't have a trillion of research on this one. We have very minimal research studies, but whatever research has put forward to, they have come up with a conclusion that the COVID vaccines are effective and safe with the second and third trimester. And those mommies who have had COVID or who have had COVID vaccines seems to have antibodies got transferred to the baby, and the breast milk has antibodies too. So I don't know to what extent, I don't want to say this is like a 99-100% accuracy results, but on most of the research studies and even the places I work with, we have been educating mommies, like, once you get the COVID vaccine, like, the breast milk has seen, and some of the researchers have proven that the breast milk has the antibodies, which is getting transmitted to the baby, that's giving like a vaccine immunity to the baby. So that's a good news for us. So that's a good, if it can be like 100% substantiated, that would be really awesome, because antibodies getting transmitted in utero and through breast milk is going to be effective with the COVID thing too. So this is all about my topic. I think I've pretty much covered everything. So optimal breastfeeding practices, all the three major topics is the major thing. The COVID thing is just, I just want to add a little bit more information just because it was a pandemic time. But as I said, it would the major 3 points will be just early initiation, exclusive breastfeeding, and then breastfeeding for 2 years with supplementing or complementary feeding. Thank you. Thank you so much.
Anjali?
Yeah, madam.
Anjali, it's so very, very elaborated talk. This is
Okay.
okay, but little long. That's why. Okay. Anyway, students, they are very benefited from your speech and other things. Thank you very much, my dear.
Thank you, madam. Thank you.
Thank you, ma'am. Today we had the opportunity to hear your valuable thoughts, and thank you, ma'am, that you have found time out in your busy schedule, taking your time to prepare for such a wonderful presentation and demonstration regarding breastfeeding, ma'am. It is very useful to us, ma'am. Thank you, ma'am.
Thank you, Maithili.
Thank you, ma'am. Ma'am, participants have shared their queries in the chat box, ma'am. We have a few questions, ma'am. Ma'am, is there any laws related to breastfeeding, ma'am?
So we do have that's something I was going to get. The federal and the republic law recently states, like, we need to have a lactation station and lactation breaks when we are a working mom. So when you start working any part of the world, they are supposed to have breaks. Like, if you're working an 8-hour job, you need to have at least like a 20 or 30 minutes of like break at least every 4 hours, so that you can start pumping and you can save the milk for the baby. And it's the same with the lactation rooms too. So every lactation room is supposed to have a hand hygiene station, a refrigerator, because with the breast milk, problem is like you have to refrigerate the breast milk. The breast milk can be on the room temperature for 4 hours. And very rarely it can go up to 6 hours, but usually we say the standard and the golden time is 4 hours. So we need to have a refrigerator. We have to make sure it's refrigerated, and then a hand hygiene station and all that stuff. So the federal and the republic law was stated that we are supposed to have lactation rooms and lactation breaks when you're a working mom. And there are like many laws. And even over here, there's one of the other civil laws, like you can breastfeed in public. There's like no authority for anyone to say you have to stop breastfeeding when you're in public area. You have all the authority and right to breastfeed your baby, even if it's a public area, or if it's a federal building, or if it's a government building. No one has the authority to come and tell you need to stop. This breastfeeding is not good. You have to stop. No, you have the right to breastfeed anywhere.
Okay, thank you, ma'am. Ma'am, do we need to take any precautions while handling the breast milk, ma'am?
Precautionary wise, it's just the standard precautions that we take, even if it's a COVID positive mommy. Just making sure it's you wash your hands and you make sure all the hygienic practices are maintained. You make sure you don't contaminate the breast milk. So whenever you put your nipples on, if If it's direct breastfeeding, you clean. But if you are pumping and giving to the baby, you should make sure you don't touch the nipple area, because the nipple area is the one that goes into the baby's mouth. It's considered as the most clean. It's not sterile, but it has to be the cleanest area. So you make sure you don't touch any part of the nipple that goes into the baby's mouth. And very precautions with handling is especially done when you're thawing the breast milk. Like when you have a breast milk that's refrigerated, you have to be extra precautious when you're thawing it, because once it's thawed, it has to be given to the baby as soon as possible. Try not to keep in the room temperature for a long time, because the more it stays on the room temperature, it can go up to like an hour. But anything more than like an hour, there is a chance of harboring the microorganisms that can definitely cause diarrheal disorders. So we make sure you have to thaw it and give it as soon as possible.
Okay, ma'am. Thank you, ma'am. Then how to thaw breast milk, ma'am?
Usually, breast milk can be stored up to 6 months, but it can go into an extended period of 1 year with adequate pumping. So when you thaw, what you do is like you get tiny sachets. That's how you store the breast milk. You get that like tiny sachet. You take one sachet out. You can put it in warm water, not hot water, just warm water. You can take a bowl, put it in the warm water, and then you have like tiny breastfeeding. It's called warmers. You call it breast milk warmers. It's just like a 10 to 15-second warmer. You can just like put the milk in there. It just warmed up to body temperature, just room temperature, body temperature. That's it. It doesn't go past that time because it's automatic setup. It's only for like good 10 to 15 seconds. It automatically cuts down, and then you can give it to the baby. It's a thawing process over here.
Okay, ma'am. Ma'am, then it is advised to feed the milk from engorged breast, ma'am.
Yeah, breast engorgement is usually it can be out of lactation. It's called lactational engorgement. But the severe version of it is lactational mastitis. So if you have lactational mastitis or lactational engorgement, it's still okay with breastfeeding the baby. But the problem with the mastitis is like if you have an infection and if you spike a fever, then when you get started on antibiotics is not one of the major things that can go compatible with breastfeeding. So there is like a wide, elaborative number of antibiotics that doesn't go well with breastfeeding. So you have to make sure if you start taking antibiotics, you have to check with the doctor to see if you can breastfeed, because certain antibiotics can cause diarrhea for the baby and it may not be really good for the baby. So if you start on antibiotics, it's an issue, but otherwise, even if it's engorged, it's fine. The problem with the engorgement is like the baby has trouble latching on. So what you do is like you just you have to hand express it a little bit so your engorged tissue gets softer so the baby can latch on faster. But otherwise, you can definitely breastfeed. It's totally fine. Even with COVID, we breastfeed. So that makes a huge difference.
Okay, ma'am. Ma'am, last question, ma'am. Socio-cultural factors that is faced while breastfeeding in Florida, ma'am. Is there any?
Social culture. So breastfeeding, there has been a big difference. Like, when I was reading through the presentation, US has been one of those states which there was a lot of like people who were supplementing. But now there's a big difference. I've seen like parents coming in and the first thing they say is like, you're a breastfeed. It's a changing thing right now. People want to breastfeed. They want organic breastfeeding. And they spend like hours and hours of classes. And the first thing that mommies come, I have seen like C-section mommies, they come from OR and like in an hour, they're sitting up saying like, I need to breastfeed. So it's making a huge difference. People are coming around and they started realizing how important breastfeeding is. Like I literally thought like Indian people were really good with breastfeeding. They are so committed, but now things are starting to change. A big difference. People want to breastfeed. People are doing breastfeeding. We have a good lactation team in the hospital, and the parents are really into breastfeeding right now. I'm seeing a huge difference, very huge difference with breastfeeding. Yeah.
Thank you, ma'am, for clarifying our participant doubts, ma'am. Thank you so much.
Thank you. Yeah.
Thank you, ma'am. Ma'am, as a gratitude from our PPG College of Nursing, has we honor appreciation certificate for you, ma'am.
Thank you so much. Thank you.
Thank you, ma'am. Last but not least, I request Ms. Celsia from final year BSc Nursing to give a vote of thanks.
Good morning, everyone, to the one road present here. So, we have reached the end of this beautiful session. First of all, I would like to thank Almighty God for making today's session a great success. It's such an honor for me to get the opportunity to thank all dignitaries. On behalf of the Nursing Department, PPG College of Nursing, I extend a warm welcome to the people in the gathering. Initially, I express my gratitude by wishing you all a happy World Breastfeeding Week 2021. The theme of the year is Protect Breastfeeding, a Shared Responsibility. It is about how breastfeeding contributes to the survival, health, and well-being of all. I would like to express my gratitude to all esteemed delegates for the webinar of their presence and contribution to make this webinar a great success. I extend my gratitude to our Honorable Resource Person of the Day, Mrs.Anjali Baji, Ma'am, Master of Nursing Science, Registered Nurse, Perinatal Nurse, Preceptor, Advent Health, Florida, USA, to take out time from our busy schedule to grace the event. Thank you, Ma'am, for inspiring and encouraging us with your words on this special day. Thank you, Ma'am. The session was much informative. I extend my heartfelt thanks to our Honorable Chairman, Dr. L.P. Thangavelu, Sir, and our respective correspondent, Mrs. Shanti Thangavelu, Ma'am, and joint correspondent, Mr. Akshay Thangavelu, Sir, for providing constant support conducting the webinar. A special thanks to Dr. P. Muthulakshmi, Ma'am, the Principal, PPG College of Nursing, for providing immense support to make the webinar successful. I extend my gratitude to Dr. Jebali, Ma'am, Professor of Child Health Department, PPG College of Nursing, to organize a webinar even amidst the pandemic. I must thank the organizing team, volunteers, for working hard for past few days to make the webinar successful. In conclusion, I congratulate all the winners as well as the participants for their active participation. Thank you, everyone, once again for making it a great success.
Thank you, Celsia. Thank you all for this wonderful webinar and making this third day webinar successfully. Once again, we will meet tomorrow for the next day session at 10 a.m. with the same link. Till then, it's bye from PPG. Stay home and stay safe. Thank you all.
Thank you, Anjali.
Thank you, sir. Thank you, madam.
Thank you.
Yeah, I will come online now.
Thank you, ma'am.